Please start straight away. Give briefly your history, like the previous candidate, and your examination findings.
Good afternoon. I am presenting a case of 54-year-old male patient working as a railway officer, presented with chief complaint of palpitation since 10 years and dyspnea on exertion since 10 years. Patient,
Go a little slow, please. Go a little slow.
yeah. Okay. So chief complaint is palpitation since 10 years and dyspnea on exertion since 10 years. History of present illness. Patient was apparently older 10 years back. Then he developed sudden onset of palpitation in one function, which was regular, not associated with syncope, and relieved after some medication.
Is it always exertional?
No, sir, not exertion.
Then what?
It is sudden in onset and sudden in offset.
Oh, okay.
That was one episode only.
Yeah, first episode. And then this palpitation episode gradually become more frequently since last 10 years. And after 6 months, this dyspnea on this palpitation is also associated with dyspnea on exertion. Initially, he was able to walk around 2 kilometers without any dyspnea. And later on, this dyspnea was gradually progressive over the period of 10 years.
Is palpitation always at rest, or it is both at rest and on exertion?
Palpitation is only at rest, and this symptom of palpitation gradually dyspnea is also started. But dyspnea, palpitation is not associated with dyspnea.
How do you know the severity of palpitation?
I didn't get it.
Even I didn't get
The severity of palpitation. Is it moderate or mild? How do you know?
For palpitation, there is an NYHA classification. Mostly in this case, this is NYHA grade 2 because
Palpitation leads to something.
but this palpitation not associated with any syncopal.
Okay. So palpitation leads to syncope, angina.
No.
That is really important.
Yeah, I mentioned this palpitation not associated with any syncope and unconscious and relief after some medication.
Regularly you go?
This is regularly according to patient. Mostly he feel like a regular nature.
How long does each episode last? How long does each episode of palpitations last?
I still don't get your symptomatology. Is it are the symptoms intermittent or they have been persistent for last 10 years that you said? You said 10 years ago the patient had palpitation and dyspnea. Then you said it was one single episode.
This history started with single episode of palpitation in one function. Then this palpitation frequencies gradually increase. Suppose during the last 10 years, this palpitation occurs only at 1 and 2 months, but gradually it occurs during 15 days or 20 days of duration.
So he's been getting
Episodes of palpitation, which is
okay. So he's been getting episodes of palpitation.
yes, sir.
And when he gets this palpitation, he also gets breathlessness.
No. They are unrelated. So now, what is the reason for these palpitations for 10 years? At rest always. Episodic in nature.
Yes, mostly the arrhythmic in nature. Arrhythmic in nature.
You have to tell us the palpitations are rapid palpitations or are they slow palpitations? Did you tap and ask the patient? What the
He says
This is the
Srinivas Kumar,
rapid palpitation.
it is a regular palpitation.
Is it regular
And rapid.
Is it rapid?
Rapid.
Yes, and rapid.
And with not associated with any syncope or unconscious.
Okay. So that makes it more. Okay.
So it is rhythmic in nature,
Yeah, mostly likely arrhythmic.
like a paroxysmal SVT.
Because there is no association with any increased frequency of urination. So I am not telling is more.
That is not a very hard symptom. Not hard point. Okay then.
So apart from that palpitation, not arrhythmia, what is could lead to palpitation?
It may be the volume overload type of palpitation,
Okay.
but this volume overload palpitation is mostly due to the during exertional. But in this case, there is no
Necessarily present throughout, it won't be like episodic.
yes episode.
So breathlessness is on exertion and palpitation is on at rest.
Yes, sir.
For how many years?
Since last 10 years.
10 years. So is this breathlessness static for the past 10 years or is it deteriorating in functional class?
Yeah, 10 years back, this patient is able to walk around 2 kilometers. So, and now during the last 10 years, progressively increased dyspnea. And now patient is able to only walk around half an kilometer, but he can do his routine household activity without any complaint. So mostly dyspnea is gradually progress from NYHA 2 to NYHA 3.
Yes, sir, as I have told, just go a little slowly. We are unable to get what you are saying. Okay, please talk a little slowly. Okay, go on.
There is no history of
So, any other important, either positive or negative history?
positive history is
Any important
palpitation,
negative history you want to
dyspnea.
add?
No, no.
Already you told no syncope,
Yes,
etc.
only 2%.
Any history of orthopnea or PND
No, sir. There is no history of PND or
or pedal edema?
So
No.
what sir is asking, specifically we should highlight the negative, because it connotes some important PND orthopnea. Previously it also discussed, within the PND orthopnea, it helps us from that. We should tell you that highlight.
So negative history. There is no history of PND and orthopnea, no history of chest pain, no history of any episode of syncope or CVA, no history of long-standing fever.
Good. So, how do you approach these symptoms? Is it left heart disease? Can you say with confidence or certainty? Or right heart disease, or can't you say? Can you say with any degree of certainty whether this is a left heart problem or a right heart problem, or can't you say?
Mostly left heart problem.
How?
Because a patient has complaint of palpitation, a long history of palpitation, and
No. So you said it is an arrhythmic cause for palpitation.
You have a patient with progressive breathlessness and palpitations at rest. So are we talking of one diagnosis or are we having two diagnoses?
You have already committed palpitations is due to arrhythmia. Then why do you try to say that this because palpitations are there, it is a left heart disease? So, what is this relation? You understand my objection? That is what Sir also is saying. So no, are there two diagnoses? One is an arrhythmic diagnosis and the other one is some structural problem, which may be correlated or associated. Later on, we can draw that inference.
But generally we should try to keep one diagnosis, one diagnosis if possible. When you're not able to do everything, then you get the second diagnosis.
But it is not possible with your description of palpitations as at rest. You have been emphatic that it is only at rest palpitation, not at all on exertion. And breathless is always on exertion. There is no way you can correlate these two with one diagnosis. Yes, sir? Is it? Yes. Okay. Now let us forget for the time being palpitations. Focus on the breathlessness on exertion. And now again answer my question, whether can you say with certainty is left heart or right heart or not?
mostly the left heart, because there is no signs of.
No, you cannot say. You see, the only cardinal symptom of left heart is PND, which the patient doesn't have even on palpitations, at the time of palpitations.
If I wanted to ask you to correlate the two symptoms, episodes of palpitation at rest and progressive breathlessness on exertion, how can you correlate these two symptoms with one single diagnosis, and what is odd against that?
Mostly in patients with cardiomyopathy, both symptoms can present.
No, patients with cardiomyopathy need not have palpitations at rest. They will generally have exertional palpitation and exertional breathlessness. The one condition they will have is rhythmogenic, cardiomyopathy. You are having episodes of palpitation at rest, but you have progressive breathlessness. But the odd thing is you don't go on for 10 years that you progress from 2 to 3.
So the natural history doesn't allow that. Or it may be HOCM associated with some bypass tract causing pre-excitation and SVTs. So, but this is all far-fetched thinking. So you can't say with certainty this is left heart disease because the cardinal symptom of left heart failure is or disease is PND, which is not there. So it could be left heart or right heart disease like a pulmonary hypertension due to whatever may be the cause, or even right aortic obstruction. Severe ulnar PS, patient can present with exertional breathlessness. Okay. So anything else? So it could be left heart disease. Like what kind of diseases you want to consider?
Left heart disease, maybe the left ventricular artery obstruction disease.
Like?
LVOD.
No, again, there are different types of alveolar obstruction. Would you like to consider a fixed alveolar obstruction like valvular AS or a dynamic subaortic?
More likely subvalvular obstruction, because in valvular obstruction, once there is a dyspnea is started, there is a very short history of. There is no such long history of dyspnea of 10 years.
Be open with your mind. Don't get the diagnosis directly. So, such village female, village male comes with long-term India versus translation. In India, probably still you could tell valvular had the first problem.
Ischemic cardiomyopathy, ischemic heart disease maybe, cardiomyopathy, and valvular heart disease.
Ischemic cardiomyopathy won't have such a long history. And he still,
Could this be mitral stenosis? See, mitral stenosis patients typically, according to all classical naturalist studies, there will be a particular functional class for a long time before they deteriorate into the next class, unless the natural history is punctuated or influenced by development of atrial fibrillation, etc. So that should be still considered here. Okay, as Dr. Sreenivas Kumar has rightly suggested, first things first, common things first. So in India, you should always respect the valvular heart disease, rheumatic heart disease. Okay, then go to the other things. One is mitral stenosis. As sir said, ischemic cardiomyopathy strongly ruled out in view of the long history. So please, all of you bear in mind, you should approach the symptoms of a particular patient with the natural history of that particular lesion in your mind. Is it possible from the standpoint of the natural history to have this kind of symptom for this long a period? It's very important. You see, any symptom can occur in any disease. That does not mean you will consider all the list in a particular patient. You will put through the sieving, what you call, filter it by the natural history. Is it possible? It is very important. Okay. So, 10 years history of not a very progressive or rapidly declining function class. What else other than a mitral stenosis?
It is a hypertension with hypertensive heart disease and diastolic dysfunction.
Okay. Anything else?
This cardiomyopathy,
What dilated cardiomyopathy? Again, it's not possible for 10 years not to have congestive heart failure.
progressing from 2 to 3 over 10 years, dilated cardiomyopathy.
You talk. What kind of cardiomyopathy, if you want to consider, what cardiomyopathy we might consider with this history?
Obstructive cardiomyopathy,
Hypertrophic obstructive cardiomyopathy is very possible with the same function class of exertional breathlessness for many years before they deteriorate. This is very important. Okay. So there is a strong possibility here. And then pulmonary hypertension, idiopathic PAH, is it possible for 10 years to remain in the same state?
Patient is a male and age is around.
No, that doesn't mean anything. No, you see, there is a classical study of pulmonary arterial hypertension studied, if I remember correct, by Chitra Institute in India. There is a equal incidence of male and female. Equal incidence of male and female. That is, doesn't militate against the consideration of pulmonary hypertension, just the gender. Okay. What perhaps militates against the consideration of PAH in this patient is the duration again for 10 years without much deterioration. They usually succumb to it. Okay. Then?
Policy, the examiner is suggesting something, which the other is totally against it, try to accept it and try to find some distance to say it. That is definitely they will be helping you like that, just for the other sake.
So what is the age of the patient? I forgot.
His age is 58 years.
58. Anything else?
And past history, there is a tension.
Valvular AS you don't want to consider. Why? Again, from point of view of natural history. What is the natural history of a severe valvular AS? Untreated natural history.
And if patient is asymptomatic, severe AS, there is a long asymptomatic period. But after developing of the symptom, if dyspnea is developed, there is a mean survival age around 2 years. After developing of syncope, mean survival years is around 3 years. And after developing of angina, mean survival here is 5 years.
Five, three, two or 1.5.
532 syncope, angina, distributed cold versus syncope. Anyway, long history, that's why it's less likely. 15 minutes over. Go to the
Is ASD possible with this history? Yes, it is possible. Why not? Very much possible. In an adult patient with long history of breathlessness. Why ASD patients become more symptomatic after the age of 40? What are all the reasons for that?
Developing RBE failure or
No, no.
due to pH, development of the pH.
Very good. Development of pulmonary artery hypertension. Anything else?
Due to arrhythmia.
Atrial arrhythmias. Very good. Development of atrial arrhythmias.
This patient had regular
Then what else? What other reasons for the development of deterioration in functional class in an adult ASD patient? One is pulmonary hypertension. The other one is atrial arrhythmias. The third one is development of left ventricular diastolic dysfunction, age-related hypertension, coronary artery disease. For the same size of ASD, the left right shunt is increased. So increase in the left right shunt in ASD patient, in adult patient, ASD adult patient, because of LV diastolic dysfunction, that deteriorates the function class. These are three important reasons. So that is possible in this patient. You should consider it is not unoften that you come across an ASD in a patient of this age. Okay. Yes, examination.
My patient is conscious oriented to time, place, and person with a BMI of around 24.3 kg per meter square, saturation of 99% on the room air, pulse is 80 per minute regular, pulses difference in character, normal volume, no radial delay, no radiofemoral delay, or peripheral pulses are palpable, arterial wall is palpable. BP in the right arm is 130 by 80 mmHg, and in the left arm it is 128 by 80 mmHg. In the right lower limb, it is 144 by 84 mm.
Can you repeat the pulse, please?
speak a little slowly so that we can.
The pulse is 80 per minute, regular, pulses difference in character, normal volume, no radial delay, no radiofemoral delay, or peripheral pulses are palpable, arterial wall is palpable.
Very good. Continue.
BP in the right arm, the left arm, it is similar, sir, 130 by 80 mmHg. In the right lower limb, it is 144 by 84 mm. JVP is not raised. Normal waveform are visible in the lying down position with normal respiratory variation. Hepatojugular reflex is absent. Peripheral sign of CAD is absent. There is no sign of infective endocarditis. On CVS examination, inspectory findings are confirmed on the palpation. Chest is normal in shape and size. No
What is the
visible
apex, please?
trauma.
Can you tell like about apex?
Yes, sir. Apex beat is visible in the fifth intercostal.
No.
space.
You don't have to tell at your level inspection separately and palpation. Combine both and tell.
Yes. Apex beat in the fifth intercostal space, localized slightly medial to the mid-clavicular line. Apical impulse is forceful, sustained, heaving type, and it is a triple ripple in the character. It is LV type. No parasternal heave is
Apex is not ripple. There is a triple ripple at the apical area. Both are, there is a difference between the two. Okay.
and, no parasternal heave. P2 not palpable. LVS3 no palpable. On percussion, riverdness in the right side fifth intercostal space. Right heart border is substernal. Left heart border correspond to the apex. On auscultation, S1 is normal. S2 is narrow split. S4 present, no S3. At the mitral area, there is a grade 2 by 6, a high pitch pansystolic blowing murmur, blowing in character, which is best auscultated in the left lateral position at the end of the expiration with the diaphragm of the stethoscope, and it is not radiating.
No, the description should be more complete. Description of the murmur should be more complete. Can you repeat again? Murmur description.
The murmur is grade 2 by 6, high pitch pansystolic murmur, blowing in character, which is best heard in the left lateral position at the end of the expiration with diaphragm of the stethoscope, and it is not radiating.
Not
Uh, Not related, sir. In the third intercostal space.
No, no,
left-
anything, have you checked with some kind of dynamic auscultation about this one?
Yes, sir. It increases on the, sir, expiration, sir.
Any other thing?
No, 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 we are
Yes.
talking about this one.
Any other thing you have to do, especially when you have such findings?
So decreases with the Valsalva maneuver, and the sir and it decreases on the standing also.
Hand grip, have you
Hand
checked?
grips increases.
Hmm?
So it decreases in the hand grip, sir.
Decreases.
It's pansystolic murmur at the apical area.
My question is, have you tested the murmur with hand grip? Isometric exercise by hand grip.
Yes, sir.
So what is the effect of that on the murmur intensity?
So it increases, sir.
Decreases. Okay, okay, continue.
In the left third intercostal space, there is a grade 3/6 crescendo, decrescendo, high pitch ejection systolic murmur, which increases on standing, decreases during the strain phase of the Valsalva maneuver, and best heard with the diaphragm of the stethoscope. It is not relating to the character.
Is decreasing in the strain phase,
Increases on the strain phase of valve.
increases on the strain.
Strain
But
phase of
standing
valve.
from squatting? From squatting to standing?
Squatting to standing, it increases, sir.
Increases. So first complete the description of the murmur at rest. Complete. Then tell about the dynamic auscultation. Don't mix up both.
Yes.
Okay.
Sir.
No, repeat, please. Repeat. No, please repeat.
Repeat. At the left third intercostal space, grade 3/6 ejection systolic murmur, crescendo, decrescendo.
Is it rough, rasping, or is it harsh? Something like that you have to tell. Always there should be adjectives used about the character and intensity and pitch of a murmur. Don't simply say ejection systolic murmur.
Harsh,
Okay, harsh.
and best heard with the diaphragm of the stethoscope. It is not relating to the characteristics. On dynamic auscultation, murmur increases during the strain phase of Valsalva maneuver, and it also increases during the standing position.
From squatting to standing. Okay. Anything else? Again, during your examination, by chance, was there an ectopy occurring? If it were to occur, what would you expect the murmur to behave like after the ectopy?
So after the ectopic, exosia murmur increases.
No, we are not talking about it, HOC murmur.
And yes,
We are all only talking about perhaps an alveolar murmur because you have a heaving apical murmur,
sir,
LV
if it
apex.
is due to the valvular obstruction at the alveolar murmur, it decreases after the ventricular premature.
Okay, we'll discuss that a little later. Continue.
The other systemic examination.
Okay, now give your diagnosis.
Left ventricular outflow tract obstructive disease, most likely HOCM, with a mild pulmonary venous hypertension, no pH, in normal sinus rhythm, with no evidence of infective endocarditis in NYHA class 3.
Describe two murmurs.
Yes, sir, with mild MRs, moderate MRs, mitral regurgitation.
Regurgitation, not MS.
Yes, sir, and mitral regurgitation.
Okay. So why do you say it alveolar obstruction? Why do you say it is dynamic alveolar obstruction? Why is this not that the apical murmur is a conducted murmur of HOCM itself? Why do you say there is an MR in addition to HOCM?
The predominant murmur is the, sir,
No, alveolar obstruction. Why?
because on the dynamic auscultation, sir.
No. See, you say alveolar obstruction just because of dynamic auscultation? You say alveolar obstruction because of heaving apical impulse, a palpable LVS4 and auscultable LVS4.
Because of heaving apical impulse, sir.
An early peaking murmur or is it a late peaking murmur? The peaking of the ejection systolic murmur is very important. Trying to distinguish between the two.
Late peaking murmurs.
It's a
Okay.
late peaking.
Okay, we accept it is an alveolar obstruction.
It is a feature of valvular aortic stenosis. Okay. If you have significant valvular aortic, so what are the other features of significant valvular aortic stenosis murmur?
No, how to differentiate? That's what sir is trying to ask. When you have an alveolar obstruction, you want to know whether it is a dynamic alveolar obstruction versus a fixed valvular obstruction. No, first go with the pulse. Is pulse useful?
Different, sir.
No.
Pulse is the speed.
No, how is the pulse in a severe valvular AS? How is the pulse there? How is the pulse in a severe valvular AS?
So rising and late.
So pulsus parvus et tardus. So when you palpate the carotid pulse, if the pulsus parvus et tardus, it goes in favor of valvular AS. On the other hand, if you palpate a brisk pulse, which is bisvariant in nature, it goes in favor of a HOCM. So pulse is very useful here. Then coming to the apical, palpation of apex, how does it help?
It is forceful and sustained, so most likely due to the.
So you will have a heaving apical impulse in both situations. You will also have a palpable S4 in both situations, but you have a triple ripple where the apex is bifid in nature, that goes in favor of a HOCM rather than this thing. Okay. You have S4 plus heaving impulse only, then it is what you call valvular AS. If you have S4 plus bifid impulse, if you have a bifid impulse, it helps you to suggest that it is a HOCM. Then what else? The conduction of the murmur to the carotid goes in favor of a valvular AS. There will be no carotid conduction in HOCM. The location of the murmur may not be much useful. Then second heart sound, will it be useful?
That's only in severe aortic stenosis.
It is mostly single type or narrow split. Narrow split or in very severe it is.
Where do you get paradoxical split? In valvular AS more often or in HOCM more often?
Valvular, yes.
So you'll get in HOCM also. Okay. So how do you make out a paradoxical split when you are clinically examining the patient?
Paradoxical split in.
Huh?
Repeat the question.
How do you diagnose a paradoxical split when you are examining the patient by auscultation?
Sir, on auscultation, if during the inspiration there is a single sound, and on the expiration, if there is a both the sounds are heard, E2 and P2 are audible, sir, then it is a paradoxical.
Again, do you make him take deep breath or deep expiration, do a deep expiration, or is it normal inspiration? That is important. So, okay, then what else? Now you go to dynamic auscultation. So how does dynamic auscultation help to differentiate a fixed valvular obstruction versus dynamic subaortic obstruction?
Type of murmur also is slightly different. And now dynamic auscultation, how is it different?
So on dynamic auscultation, if it is due to the valvular obstruction, on sir Valsalva, it is the murmur is decreases, sir.
Valsalva means what? Which phase of
maneuver,
Valsalva? Huh?
during the strain phase of the Valsalva maneuver.
Straining phase of Valsalva. Okay. Then?
And from the squatting to standing position, murmur also decreases, sir, in the valvular obstruction.
What are all the murmurs in your clinical cardiology that get accentuated when the patient stands from squatting and also on straining phase of Valsalva? One is HOCM. What other murmurs?
Mitral
Prolapse.
murmur prolonged, sir, in the
So what is the mechanism of increase in intensity of HOCM murmur during the straining phase of Valsalva? Why does it happen?
Sir, due to the dynamic. During the Valsalva phase of murmur, there is a during the strain phase of Valsalva, there is a decrease in the LV blood flow, due to which there is a dynamic dynamic outflow tract.
So there is a reduction in the preload.
Sir.
Okay.
Yes.
And there is a reduction in the preload, the alveolar obstruction increases. Reduction in the preload, reduced afterload, increased contractility. These are the three reasons when which cause the increase in the alveolar obstruction. So because of reduced preload, there is an increase in this thing. So what else? No, finally, one important this thing I have already asked. If there is an ectopic occurring, or if you give an ectopy during cath, what are the differences that happen hemodynamically between HOCM versus fixed AS?
The Braunwald phenomena, sir.
Broken barrow, Braunwald sign. Okay. What is it exactly?
Sir, during this, sir, if after the VPCs, sir, there is a pressure difference is increases, sir, in the HOCM.
So what will happen during the post extrasystolic potentiation? There is a prolonged pause. So diastole is increased. So preload increases. So increase in preload should reduce the alveolar obstruction in HOCM. But by Frank-Starling law, Increase in preload also increases the contractility. So the effect of the increase in contractility far much outweighs or predominates over the effect of preload, increase in the preload, thereby increases the alveolar obstruction. What will happen in fixed alveolar obstruction? In fixed alveolar obstruction also gradient will increase. So clinically the murmur will increase after an ectopy in both HOCM as well as valvular AS. The only difference is pulse pressure is reduced in HOCM, whereas pulse pressure is increased because of increase in cardiac output in valvular AS. This is the difference between the two.
I will look at this. I will look at this.
This is the sir, normal sinus rhythm with the normal axis, sir, with the left ventricular hypertrophy with the pressure overloads, LVH with LV strains, sir.
If the T wave inversions were deeper, then that is a feature of what type of
Pressure overload situation.
primary cardiac. This is that called. Yeah.
Yeah, you can read those there.
Yes. So the echo diagnosis shows that this is the case of hypertrophic obstructive cardiomyopathy, and there is a asymmetrical septic hypertrophy. IVS is 20 millimeters, posterior wall is 15 millimeters, and there is a resting gradient across the LVOT of 68 millimeters of mercury, and grade 3 SAM is present. So how do you define asymmetrical septic hypertrophy?
Sir, if the LV endosteric wall thickness is more than 15 mm. Difference between the IVS and the posterior wall ratio is more than 1.5.
Yes. That is.
What is the current understanding of the reason for dynamic obstruction? Mechanism of dynamic obstruction.
There is a mostly first is the due to the venturi effect of the sorry.
Yeah, that was previously thought of like that. What is the current understanding? Drag force of the flow, an abnormally positioned anteromitral leaflet. Okay. Then, because of the gradient between the difference in the pressure between the LV and LVOT, LV body and LVOT, that will further push the mitral leaflet towards the septum, hypertrophied septum. Okay. We'll stop here. Yeah, we'll stop here. Yeah.
Sir, is the resting gradient is more than 62, I think, more than 50 mm Hg, sir. 68 mm Hg, sir. So we can go for this, sir, septal. First we go to medical treatment, beta blocker or calcium channel blocker. The patient is even symptomatic after the beta blocker or calcium channel blocker. Then we go to the.
So if your patient doesn't respond to beta blocker, which is the calcium channel blocker that we use?
Verapamil or.
Yes, only verapamil.
What is the latest drug
Yes.
that is being?
Dipyridamine is.
No, latest drug.
Mavactam, sir.
Latest, what is the second category of drug?
So myosin inhibitor, Mavactam.
Before that, sir, is asking other drug which we used to use before.
Which has a profound
Dihydropyridine.
disopyramide.
Yeah. So you use these first two drugs, and if your patient is still not responding, then you use mavacamten, not available right now in India. And
So one thing I will tell from echo and correlating with your examination and your conclusion, there is no significant mitral regurgitation in the echo. And the murmur which you said you have had at the apex has decreased with your hand grip. That is strongly goes against a mitral regurgitation. You understand? So same murmur of alveolar obstruction you had at the apex also. I think we'll conclude this session here. Thank you very much. You have done well. Okay.
Thank you.